Dr. Sakran is here, who's a trauma surgeon at Hopkins, and he has many titles, but the way I was introduced to him the first time was that he's basically the mayor. He knows everybody.
Thanks so much, Dr. Ho. And good morning. It's really great. It's really great to be here. Just a couple things. The first is this has really been just a tremendous morning, and just listening and understanding the different perspectives have been so valuable. So I just want to recognize Dr. Ho, Bulger, Kirby, and the rest of the team that had the vision to bring this together. Really, really awesome. So just a couple things. The first is I'm wearing sneakers, and I know a couple of you have looked at it. It's not to be cool, as Dr. Sakran pointed out, but I'm like a hot mess this morning. Everything fell apart as I was like walking out of my room, so I apologize for that. And I also apologize for having to leave today, but I had a little bit of a conflict in my schedule, but I just think that it's going to be really great to kind of hear what comes out of this process. I'm also going to disclose that I'm going to, as I typically do, push a little bit of the boundaries today. And so I hope you guys are okay with that. And a lot of this builds on some of the incredible work and discussions that we've already begun to have. And what I'll just initially disclose, not that I'm going to specifically discuss this, but in the spirit of transparency, I am the chair of the board of directors for Brady, and just recognize that. So I'll briefly, in the short time we have, talk a little bit about understanding inequality, but I'm going to spend most of the time talking about what we term the political determinants of health, and then really finish up with highlighting some aspects that are critical as it relates to civic engagement and storytelling, some of which you've heard me give in the past. All right, there we go. So when we think about, oh, that went too fast. When we think about inequality, I think it's important to recognize that inequality is not by accident from the mere economic reality or individual talent. It is determined through the struggles that take place through the political sphere. And so if you think about resources and advantages obtained through the political sphere that are not equally distributed through population groups, it should not be a surprise that health outcomes and premature death are not equally experienced through population groups. And I really love this recent affirmative action dissent by Justice Sotomayor, where in her dissent, she talks about how equality requires us to acknowledge inequality. And I think that's something that historically we haven't done a really good job of. Now, a lot of you have seen this graphic that's listed up here. This graphic is common to many of you, but I wanted to highlight it because the fact is that it's critical for us to focus and better understand those individual components downstream. But the upstream factors will allow us to dismantle the inequities that exist in healthcare and public health. And so we can't lose sight of that because that's really getting to the root causes. Now, you heard the discussion this morning about research and the need for more research. There are a variety of gaps that exist. And in order for us to be able to address them, right, we have to really think about this in a multifaceted way. We heard this morning from Dr. Tan about the social construct of race. But in addition to that, we need to explore issues from the intersectional, the social, the ecological, and the overall comprehensive integrated approach that is so critical. You heard Dr. Bulger and others talk about the intersectionality. And I love, that term, and I've been learning a lot about it. I think that term, which by the way is coined by Professor Kimberly Crenshaw, I think really provides a prism for us to see the ways in which various forms of inequality often operate together and can exacerbate each other. But like we heard from Dr. Zarzar, we have to have the right methodology and the right ability to be able to move that needle forward. Can you guys get the slides back up, and I'll just continue talking? The other thing that we really need to focus on is really trying to determine and figure out how do we peel back the layers to have the best data-driven, right, policy-relevant and action-oriented solutions. We heard a question earlier about, well, okay, great, we're all talking about this stuff. Well, what are we going to do, and how are we going to be action-oriented? Well, part of it, I think, starts in rooms like this, and Dr. Bulger mentioned what we've done, through the college and other organizations around firearm injury prevention, right? It's first coming together, understanding, who the folks are, and how do we work together in a way that allows us to move the needle forward. I'm just going to maybe keep going, I guess, or. So if you can imagine the slide, right? The slide is up there. What this slide shows you is it shows you the ranking in the U.S., okay? And the ranking in the U.S. as it relates to health security. So there's this Global Health Security Index. And this Global Health Security Index, what it does is it compares 195 different countries, okay? And it compares these countries and it looks at a lot of the different factors that exist. And one of the factors, here, okay, maybe. I'm going to the, okay, perfect. So that you can see here, these are just a very small number that I listed up here. But I wanted to show you where we as a country stand. You can see whether it's, the public health vulnerability or socioeconomic resilience, right? We're not doing great. But take a look at the last one, healthcare access. We are 183 out of 195 countries. Like, that is embarrassing, okay? And you think about who is greatly impacted by this. It's the most marginalized and vulnerable patients, right, and people in our country. Now, Dr. Berry talked a little bit about the economic burden, right? This was a great piece that was done by Deloitte. If you haven't seen it, they did some very elegant work to look at the modeling and the cost of health inequities. So right now, every American is spending about $1,000 a year on this. It's about $320 billion. Look what happens by the year 2040. We're going to be above $1 trillion. So this is critical for a whole variety of reasons, one of which is often what leaders and policymakers look at and listen to is the economic impact, right? It's not the moral argument, as unfortunate as that may be. So we really have to, understand and figure out how do we connect the social determinants to their policy roots. And I will just say that, like, when you look at different institutions, right, and you look at organizations and bodies like the Supreme Court, there's a lot of very interesting views on inequities. I would submit to you that the Supreme Court would rather view inequities as products of private choices or products of social determinants of health. So that way they don't have really a constitutional or legal enforceable remedy. Now, we, right, as health equity champions, I think are responsible to not entirely think about this as a socially derived issue. And if we fail to do so, if we fail to make that policy and political connection, we're only going to bolster those type of arguments and beliefs. And we're going to weaken kind of the legal protections that exist. And what that does is that doesn't allow us then to really put these institutions in check. And it continues this form of discrimination, as well as denying, frankly, the legal remedies that could really help impact some of these inequities. So we know, I think, all too well that racial and ethnic minorities people with disabilities, lower socioeconomic status, LGBTQ plus individuals, and those in rural and frontier communities die disproportionately every year. And when you think about, well, how did this happen, right? It's a variety of forces that are collectively impacting our health. We know it's environmental, we know it's behavioral, we know it's physical. And of course, one of the key factors are the social determinants that, as you can see based off this graphic, plays an outsized role in these human-made pre-existing inequities. But what we also have to recognize is that underlying each one of these is a political determinant that we can no longer ignore. You know, too often we've skipped, right, and we've stopped at the social drivers of inequities, failing to look back and to dig even further to see what the depths of the problem and understand the root causes in the distribution. So this is something that I think as we start to understand all these different, very complex components, right, we have to recognize the fact that the social determinants of health for every one of them, there is a law, there's a regulation, a legislation, right, or some other policy decision that has resulted in the structural conditions that we find ourselves in. Now, I've had the privilege of working a lot with Daniel Dawes, who was down at Satcher Health Leadership Institute and now is at Meharry, and he's written this incredible book, The Political Determinants of Health. I highly recommend it if you want to learn more about this. I'm going to talk a little bit about this, but what I would say is he describes in this book, right, that facts that are evidenced in data, where research has shown how high obesity rates, diabetes, maternal mortality, infant mortality, gun violence, right, and the list just goes on, how these are linked to policy actions or inactions. And in the U.S., our community health is not an organic outcome. It's not a fluke that some groups experience poverty for generations, blocking them from attaining the American dream. Our system, or I should say systems, have not valued each group equally, or frankly, even realized the long-term implications. And there's a whole list of reasons as to how we got here. When you look at, slavery and the epigenetic research that's been done showing the intergenerational trauma, or as you're looking at the segregation and how it's been directly linked to aggressive breast cancers, right? All of these factors are relevant. And so when we think about the political determinants of health, in our country, the principal roots of current and historical inequities are found in them. And the effect of every one of us, right, can be impacted because it encompasses a systematic relationship, a structural relationship, distributing resources, administrating power. All of these factors come together. And there are stark differences in how negatively or positively they can affect certain individuals and communities. So if you think about a transportation policy as an example, right? If we know that transportation, of course, is a social determinant of health, right? And when a transportation policy, let's say in a local community, let's say removes a bus route, okay? Well, this bus route runs through a community of residents that rely heavily on affordable public transportation. So what happens when this bus route is removed? Well, all of a sudden, they can't get to their healthcare appointments. They can't get to their jobs. They can't, take their kids to school. And the list just goes on, right? Individuals and families, right, suffer negatively from this political determinant because it creates an inequity, right, and a lack of a resource that doesn't allow us to have and rely on public transportation. Now, a lot of the healthcare systems, they've been really creative. They come up with ways to taxis and ride shares and so forth. But that's treating the symptom, and it's not dealing with the underlying problem, right? And so when communities come together and they advocate and they gather momentum to work and to anchor institutions, they're going to successfully, right, be able to move that needle forward in a way that allows us to address those root causes. So I apologize I'm just going to keep going because I know time is short. So when you think about, like, there's been long-lasting impact as it relates to, the vestiges of slavery, segregation, and frankly, subsequent discrimination. And when you think about what's happened, in the most recent years, meaning over the past 100 years, right, there has been an effort to try to create policy that, at least at face value, was attempted to not be racist or not be exclusionary. But when you think about how they were devised, what's interesting is that they were devised in such a way that actually they still had the same effect. So I'm going to give you a couple examples. So like one is the Social Security Act, right? So a lot of you probably know the Social Security Act, right, signed in 1935 by President Roosevelt. So this law, right, created a program that essentially allowed, a variety of things, including insurance against unemployment. Well, did you know that it excluded domestic and agricultural workers that primarily impacted nearly 80% of African Americans and many immigrant groups, right? So there was, they were trying to do the right thing, but how it was devised didn't necessarily work out that way. That's the slide. All right. So the other, and you heard of, so the other, and you heard a little bit about this by Dr. Berry, is this, movement around the Homeowners Loan Act. And I want to just highlight a couple things because I think this is important. So we know after World War I, there was an effort to really stimulate the economy, and Congress, as well as President Roosevelt, developed, different things like this, right? The purpose of that specifically, I think, is so critical. It was to provide emergency relief with respect to home mortgage debt, right? Now, here's what happened. Kind of heard from Dr. Berry a little bit. So they sent out these appraisers to over 200 cities, okay? They sent these appraisers out there, and the appraisers then, aggregated these reports and came up with this ABCD system. Well, the C communities, these were primarily immigrant communities. So they were, the Italians, the Jews, the Germans, right? I mean, the list goes on, the Cubans, the Mexicans. They were deemed undesirable, okay? We're going to get back to that in a second. Now, the D communities were primarily African-American communities, and they were deemed hazardous. Now, here's what's interesting about that point, right? So it took a policy to authorize this, right, to develop that report. Then, once the report was done and aggregated, it was sent back to D.C. What do you think happened then? Well, then they used that to develop further policies that determined which communities to give home mortgage loans to and which ones not. And you can imagine that, of course, the D communities, right, the hazardous communities, were significantly impacted, as were some of the C communities, which had a lot of immigrant populations. Now, I could literally go on. I'll just, for the sake of time, just mention two other quick things. There's examples of the Highway Act where 41,000 miles of interstate highway that ran through neighborhoods, right, pushing out families that had lived in those communities for decades. And not only they pushed them out, but there were also things like putting bus depots and all sorts of stuff which led to pollution and increased asthma rates, right? So terrible stuff. After World War II, the Housing Act that was created really, one of the programs was the Urban Renewal Program. And some of you have probably heard of this, but what was really interesting about what happened here is essentially what they did was they were, selling off these property to real estate developers. And then the real estate developers, what did they do? Well, they revamped the property and they sold it to more affluent individuals, right? So you can imagine the impact of this was just tremendous. So I think there's two just global takeaways here. The first is that we have to realize that policy decisions have and continue to operate to perpetuate the structural inequities that we see in society. And from a positive perspective, I think we have a real opportunity here to think about how do we reform and improve what we're currently seeing. So I'm sorry, you can't see the bottom, that's okay. So I want to look at just a little bit really quickly, how do we leverage the structural conditions in which we and the communities can really find ourselves and work in, right? When we analyze, right, whenever we analyze health outcome, whether it's an inequity or not, I think we have to consider, how did that outcome actually exist in the first place? What was the policy in the first place that created it or perpetuated it? How did the policy or the political action or inaction result in that structural relationship in the community? How have health protective or health sustaining resources been distributed in the community, right? And how has power been administered in that community? Once that type of analysis is done, then you can move on to really implement it in a framework that allows us to be effective. One model of that framework in Daniel's book, which I think is tremendous again, is really drawing on the evidence of political science, the legal aspect, public health, and understanding the historical lens. When you look at this, the interconnecting or the circular arrows here, they demonstrate that they operate simultaneous, right, in ways that mutually reinforce each other and concurrently impact or are impacted by a continuum of interacting barriers and interventions. And health equity proponents really, I think, have to overcome those barriers and leverage the interventions, right, in order for us to be able to advance health equity so we can focus on the policies that address some of these issues in such a complex environment. When you look at this bracket on the right, and you can't see the top because it's my picture, unfortunately, covering it, but when you look at the bracket on the right, it's the relationship between the political determinants of health and the other determinants of health, which collectively then create this, action of health inequity, right? And health equity and how it relates to everything else that's happening. So when you look at this, kind of strategic process, it doesn't end once the research is completed, right? We're talking a lot about research, and research is critical, but it doesn't end when the research is completed or once a policy is realized. It requires constant monitoring to determine whether a policy or governmental action is positively or negatively impacting the determinants and the community and how it's relating to the equity, right? So we have to have due diligence as we think about this. And as we kind of, take all of this into consideration, there are a lot of different, right, components of what we face that this can be applied to. We wrote a piece in the Scientific American with Daniel and one of my mentees about the political determinants of gun violence and how some of these factors relate to this. To be able to effect maximal change, we have to be able to understand and engage with both the depth and the breadth of the problem, right? And that's done through targeted policy, right, that is concentrated, around communities where there's poverty, there's underfunded school systems, there's underperforming schools, and the list just goes on. So, I always say that policy is not always politics, and for me, I recognize I kind of cross, some of the different barriers. I think we have to really just be, have the moral courage to not be afraid to support data-driven solutions. We are, such an invaluable resource to other leaders and policymakers. Most people don't realize this, but like those folks, they're afraid of us. Like they have, we think we're kind of intimidated by them, but they're actually intimidated by us. I mean, I spent a year with Senator Hassan, and I can tell you every time there was some sort of clinician meeting with the team, the amount of work that went into preparing for those meetings was probably double, if not more, than the other meetings, because they knew that, they better come prepared. We have an opportunity to influence how they think and to make them understand in a very objective way what those solutions are. And I don't think we should be afraid of that. When you think historically about civic engagement, this was a great talk that Dr. Cornwell gave recently at the Southeastern, and he was talking about Dr. Asa Yancey, which hopefully some of you know was, just a premier leader in surgery and an educator. He started the first African-American general surgery residency program in Georgia, among many other things. But I put this up here to show that he was also part of, the public school systems and the Board of Education. And when you think about that type of civic engagement, you say, well, Why would he do that? Well, he's part of the fabric of the community, right? And this gets to what Dr. Punch, talked about a lot, which is how we engage the community is so critical. And there is often a lack of trust, not with individual providers, right, necessarily, but with the systems in place. Linking that trust, right, with that community is so critical because the people in the community, those that are closest to the struggle, they understand the solutions that are needed. And as you heard from Dr. Punch, we need to make sure that they are true partners, right? Not just getting some feedback periodically here and there. And it doesn't matter, really what issue you're interested in, right? When you think about health and the social issues that we face in America right now, whether it's gun violence or pandemics or structural racism, they are so interconnected to health, right? So there's the ability for us to really be able to be a critical part of that conversation. And, that means, often having to advocate and to raise our voice. So, there we go, okay. So I would just submit to you, and, is that don't think of advocacy as a dirty word. I think traditionally it's been thought of as like, well, we're clinicians, we just take care of patients. That's like nonsense. We do so much more than that. Okay, we do research, we talk to families, we testify, we write opinion pieces. Like, we advocate every day, Some of you are going to advocate what you have for lunch today. I mean, everything that we do, right, is that type of conversation. It's required if we're going to change some of those upstream factors. So I just would say that really kind of think about that. And it doesn't mean that every one of us has to be an advocate. But what I would say is that, even if you don't want to be an advocate, supporting the concept is so critical. Because I can tell you, and there's been surveys done even within the American College of Surgeons, that not everyone believes within healthcare that we have a role to be advocates. I'm going to skip this for the sake of time. Look, I'll just say a couple things. Look, in my experience, healthcare workers really lead to better policymaking. Because frankly, the people that are often in charge of the policymaking, they don't understand what's happening on the front line. That being said, we also have to understand their perspective and where they're coming from, right? And how to work with them in a way that allows us to be effective. And part of that is being able to develop authentic communication, which I think young people in America have done, and to be able to figure out how do you tell your own story. Now, each and every one of us have a story to tell, and I always say it doesn't have to be as dramatic as being shot in the throat, but figuring out, like, how do you tell your story and how do you communicate it is critical. When I was at the Kennedy School, one of my professors, Marshall Gans, talks about this in the sense of the story of self, the story of us, and the story of now. And the point here is that when you go from purpose, which is the why, right, to really trying to move the needle forward, that value to action, it's done through emotion. And I think we've gotten, honestly, so much better in understanding and learning how to do this. I think traditionally it's been a little bit difficult. And I remember when I first started talking about this over 10 years ago when I was in fellowship, people kind of looked at me like a little bit weird, like, okay, it's too foo-foo for surgeons. But I think we're realizing how effective of a strategy it is. And I say that because, having the right idea is great. But if you have the right idea and the wrong strategy and approach, you're going to fail. And we see that happen all the time, right? I think all of us can probably think about experiences like that. So I just want to leave you with some parting thoughts. I think, our political system really engages in a relatively predictable pattern, right? And we have to think about this as we think about advancing health equity in this country. We also have to really, I think, understand the history and where we came from, the politics, the policies, so we can have the tools to be able to advance it in a way that allows us to be effective. And then the last thing that I would say is that, exploring the different determinants, yes, the social determinants are critical, but let's not forget all of the different components that are so important for us to really be able to make a difference and to elevate health equity as a national priority. And that's really where we start talking about the political determinants of health. Research is critical to better inform, the action plan. We have to engage in collaborative, ways and make sure the community is leading the process with us. And we have to think about the commercial interest, right, and what the government invests in. They don't invest simply in the moral argument. And if you don't believe that, you're going to experience that because that's something that we historically have seen time and time again. So learning how to tell your story, I think we all need to kind of learn how to tell our own story. So I just leave you with that, like, what's your story? And I would just say that, like, Gabby Gifford has so much courage. I think of what she's been through, and I think about that a lot. Like, we all have to have, this is a little bit uncomfortable, right? We're in a space where maybe we're not used to kind of being in this space and we don't know how to navigate it. But look at the people in this room. Like, you all are incredible individuals that are doing great work across this country. Like, we can come together and figure out how to do this effectively, figure out how to minimize wasted resources, and figure out how to come up with a strategy that allows us to, instead of being, working in silos, to work hand in hand in parallel. I just want to thank, my partners who are back at home doing the hard work while I'm here. And then I just want to thank you all for the privilege of being here today, and happy to take any questions if we have time.